So I will give the next short presentation. Again, my name is Greg Dakin. I work in New York City. I do about 50% bariatric surgery, so I was going to speak on what types of emergencies that the acute care surgeon should know in terms of bariatric surgery. So whenever I give a talk about the complications or the acute emergencies of bariatric surgery, and there obviously is a laundry list of them that can occur, I feel an obligation to mention again that in actuality the relative frequency of any of the very bad complications from bariatric surgery is very low. In some of our own data, even the overall composite endpoint of very bad outcomes, death or DVT, PE, leaks, and reintervention is very low, maybe 4%. Chance of a DVT or PE, certainly under 1%, dying maybe around 0.3%. But nevertheless, there are a good variety of complications that can occur. And unfortunately, these complications may occur when a patient is outside of the hospital that had their surgery. So they may find their way to a place that doesn't have bariatric surgeons or where you may be asked to take care of them. The first thing you're going to do is look at when was the operation. That will give you at least a starting point to help differentiate what of that long laundry list of complications you're going to be dealing with. Obviously, if someone comes in a year after surgery, you're not going to be thinking leak. Leak is something that happens in the acute postoperative period. DVT can occur or PE can occur anywhere in the early postop period, even up out to 30 days, probably even a little bit longer. So it's probably always on your differential, but that's a good way to start when you're evaluating patients that come into the emergency room. And obviously, you have to be a little bit familiar with the basic surgeries that we do. I took it for granted that the SAGES audience is fairly familiar with at least the four main surgeries that are currently in use here in the United States: gastric bypass, lap band, something called sleeve gastrectomy, and then certainly less common duodenal switch. So I won't go into the details of those operations. I think we all have a good baseline knowledge, but obviously depending on the surgery, you're going to have a different set of diagnoses in mind. There are some key principles to keep in mind when you're evaluating a bariatric surgery patient. Some of them, in some ways, are a little different than many of your general surgery patients. They have a little bit different or less minimum physiologic reserve. Certainly pulmonary function is a little bit affected. Physical exam can be difficult in the obese patient, maybe a little bit less reliable. So these are all things to keep in mind. And lastly, we think it's important to act quickly. If you think an operation is necessary, delays in surgery can be more harmful than they might be in the general population. Also remember that a bariatric patient can have non-bariatric problems too. So don't forget about appendicitis, cholecystitis, any of your gynecologic acute problems can occur. So a brief word on a patient who comes in with septic symptoms. Fever, tachycardia, hypotension, and the like. The differential is wide, but there's certainly some very concerning things that could be going on, and some maybe not as concerning, even though your patient looks sick. The real question that I get asked a lot is, what's the role of imaging? And everyone wants to think when you see a patient you're worried has sepsis, you may be thinking about a leak, and many people would rush to get into an upper GI. That may not be the most useful test, certainly not going to be very helpful if it's negative. Certainly it's tempting because if it's positive then you know, but there's a lot of other things that can go on, leaks from more than just the proximal anastomosis in the case of a gastric bypass. So really CT of your chest, abdomen, pelvis is probably going to be the most widely used and most useful diagnostic test. You can get it PE, you can get it leaks from the different sites. Just remember, there really should be, for an operation that was done laparoscopically, there really should be no free air, at least one day after surgery, and minimal, if any, fluid in the abdomen if everything's going well. So these are the complications or acute problems that I chose to focus on. There probably are some others that we could deal with, but in a short period of time, I thought these would be the most important. Bleeding can certainly happen, and that's a patient who's gone home and can come back in with bleeding. It's going to present one of two ways, usually with hematemesis, so bright red blood vomiting. And then again, that's going to depend on your surgery. The sources are either the gastric pouch or the proximal anastomosis in a gastric bypass, or the big long cut line with a sleeve gastrectomy. Your first option always is to treat the patient conservatively, resuscitate, transfuse as necessary, see how they're doing. But that may not work. And so then your best course of action is to do endoscopy to try to control the bleeding. And what I want to stress is that this endoscopy should always be done in the operating room with the patient intubated and you standing by. They can have difficult airways, not universally, but challenging airways. They've got a lot of blood in there. You do not want to be trying to do any sort of endoscopic intervention without having a secure airway. Your next course of action will be laparoscopy, and you can oversew the proximal anastomosis or the gastric pouch. If they come in the other way with bright red blood, Per rectum, again, the source is going to be a little bit different. Either that, in the case of a gastric bypass, could be the remnant stomach, or say your distal staple line of the gastric bypass, the jejunogegenostomy. They can present later, years out, with other problems, just routine peptic ulcer. So again, treatment is conservative. At first, try to resuscitate the patient. A lot of these may stop. But if you need to, you probably will have to go to the operating room for oversewing. Endoscopy is going to have less of a role in this case, especially if it's an acute bleed after surgery. If they're more chronic, you may want to investigate some other standard bleeding evaluations, such as even a bleeding scan. Leak is the big dreaded complication for bariatric surgery. Again, doesn't happen very often. Nobody wants to see this x-ray on the morning of post-op day 1. That's a sleeve with a gigantic leak out to the patient's left there. They are infrequent, maybe 1% after gastric bypass. I think the number 1 to 2% after sleeve. A very high rate of mortality when people leak still. There's no consensus algorithm as to how these should be treated. But the one thing for sure is that it really may need to be treated by a non-bariatric surgeon. Most of the leaks get diagnosed after the patients have been home. Probably around 7 days is the median diagnosis, and our patients are usually discharged on hospital day number 2 at this point. So many of these patients, if they get sick, if they have a leak, they will get brought to the nearest hospital, not back to where they had their surgery. Leaks get classified. They usually present with fever, tachycardia. Your diagnosis test of choice is CT scan. And then your treatment is going to depend on the patient, whether it's an acute or chronic leak, whether it's a stable or unstable patient. But all your general surgery concepts apply. You have to treat the patient, resuscitate, explore, wide drainage, repair if you're able, and with really a strong emphasis on enteral access. This is a patient who's going to be sick for a while. You need to be able to feed them. With an acute unstable leak, so again, you want to provide drainage, you can repair depending on the operation. If it's a sleeve, you might be able to revise it or convert it to a gastric bypass. Chronic leak, you have some other options. Certainly stents have come into play. I think they're a little bit more useful for the acute leak. This is a picture of what one would look like. If you have that technology, it can be very useful in managing leaks, particularly with sleeves, because they tend to migrate a little bit less than in the case of a gastric bypass. And there are some other endoscopic interventions that many people may have and you're familiar with to try to seal up a leak from the inside. But the key is to treat the patient. If they are behaving septic, you need to get in, get drainage, resuscitate, and also do your very best to try to place a feeding tube. Obstruction is another common problem, certainly more common than leaking after bariatric surgery. There can be many different sources. This is actually a picture of intussusception, but you can have small bowel obstruction, gastric obstruction, obstruction in anastomoses. Obviously, a patient is going to come in and present with abdominal pain, nausea, retching, maybe vomiting, maybe not. Depends on what the operation is and where they're obstructed. But the one thing to point out is I think that the conservative algorithm of an NG tube decompression may not apply, particularly for bariatric patients. There's many causes: adhesive bowel obstruction, incisional hernia, port site hernia, intussusception I mentioned, but the one that we always think about is a mesenteric or internal hernia. This is very concerning, and this is why bariatric patients probably need to have a very say a high index of suspicion for internal hernia. No one wants to take a patient to the operating room and see this. Internal hernia is a closed loop obstruction. So your conservative algorithm is probably not going to apply. 3 sites of common internal hernias after gastric bypass: your Peterson space, your transmesenteric space, and again the retroanastomotic space, or your enteroenterostomy defect. There's a little bit of debate as to whether or not these ought to be closed at the time of the surgery, but even if they are closed, the problem can still happen. You can have acute and chronic presentations. In this, for the purpose of this discussion, we're leading with the acute presentation, which is going to be a bowel obstruction. But depending on which segment of bowel is obstructed, they may have varying presenting signs and symptoms. CT scan is your diagnosis of choice, but it can be misleading. It's not 100% sensitive. Don't be fooled by the commentary of the radiologist that the contrast goes all the way through to the colon. If your biliopancreatic limb is obstructed, that is going to possibly be misleading. The classic sign for internal hernia is a swirl sign, which you see on that x-ray. Again, take care of the patient. You're going to explore them, and hopefully you can do it laparoscopically. Usually work, as with any bowel obstruction, distal to proximal. Place the bowel in the right lower quadrant, and only if necessary, handle the dilated bowel. One other one that I'll mention is just intussusception after gastric bypass, which we will see from time to time. The key here is to note that probably the only way to really fix it is to revise the enteroenterostomy. I've seen some attempts at pexing and suturing the bowel together, but that's likely to recur. So probably the best thing to do is simply to redo it. And again, I think that bowel obstruction in a bariatric patient should be handled differently, maybe a little bit more aggressively than your common general surgery patient. One quick word about obstruction with lap band. Again, this, at least in our part of the country, the surgery is getting less and less common, but if a band patient comes in with an acute change, vomiting, or even reflux symptoms, that might be indicative of a slip. The test to get is an upper GI. You'll see a big dilated gastric pouch and probably a horizontally oriented band. Those are your keys. The first thing to do, of course, is take fluid out of the band. It is not, unless you're used to doing it, maybe not as easy as you might think. They're big patients. You need to have the proper needle. It's a big, long Huber needle. Make sure your patient is positioned properly, and you can have them do some crunches or Valsalva maneuvers to help you feel and palpate the port. If you can't do that or the patient doesn't improve, you need to take them to the operating room and take out the band. The key is to get to the lesser curvature side. That's usually safe, and you should be able to excise it. And then lastly, one quick word on nutritional problems, which we don't usually think of as an acute problem with bariatric patients. It's more of a chronic long-term thing, but there is one scenario that I wanted to mention that can happen acutely, and we seem to be seeing it more frequently, and I think it's actually one of the, for those of you looking for MOC, one of the questions that may come up later on in the post-test. But this is a common, not common, but this is a scenario. Patient has a sleeve gastrectomy 8 weeks prior. Frequent vomiting, which we do see with the sleeve. It can take a little bit of getting used to for the patients, and they come in having had significant weight loss, not tolerating solid food, and they have a variety of neurologic symptoms: ataxia, vision issues, disorientation, nystagmus. You guys know what this is? Thiamine deficiency. So that's an acute Wernicke's encephalopathy. It's been reported for virtually all of the bariatric operations. It's been reported as a variety of lawsuits, unfortunately, for patients who are misdiagnosed. It can result in permanent neurologic sequela. So if you see a patient who's in the early post-op period who's having frequent vomiting, even if they're not in the early post-op period, we always recommend, if they come in for whatever reason, give them thiamine. It's certainly not going to hurt. I'll draw your attention to this resource. It's available from the ASMBS website. It's sort of an algorithm chart that you can print out or put in your office, put in the emergency room, wherever. It gives you an idea of the sort of algorithm and diagnostic processes for any of the bariatric surgeries. And then lastly, there's really no shame in calling for help. Some of these things are not as simple as they may sound. We talk about band slips. It's very common, but frankly, to undo it and try to redo it can be a little bit more challenging. Even the internal hernias, if you've got big dilated bowel and you've never seen it. So there's a lot of bariatric surgeons around. Probably not too hard to get in touch with one of us to ask a question. So thank you very much.